today to discuss how we can improve management of chronic graft-versus-host disease by using ECP. So here are my disclosure. So before to go more in details regarding the use of ECP, I just would like to highlight that we have some significant improvement in the management of chronic graft-versus-host disease. We don't have this kind of slide a few years ago with 3 drugs that are now approved by the FDA, but that can also be used in most countries in Europe with ibrutinib, belimozidil, and ruxolitinib, but that approved so far only for patients that fail to the first-line treatment with steroids. Regarding the first-line treatment, so far it's still based on steroids and steroids alone. Several studies have been performed, some of them that were randomized, also they were double-blind to compare the use of prednisone alone or combined with other drugs such as azathioprine, cyclosporine, thalidomide, mycophenolate mofetil, also hydroxychloroquine or sirolimus. And as you can see here, none of them were positive, and even some of them, when you had another drugs, it was some detrimental effect which decreased survival or toxicity. So, so far, there is really some unmet need for the management of chronic graft-versus-host disease. What are they? They are the first-line treatment. We still need some drugs or some treatment we can combine to steroids to improve the response rate and also to reduce the dose of steroids we are given to the patients, because steroids are associated with a lot of morbidity. And we also can still improve second-line treatment, because despite the fact that we have several drugs available for the second and third-line treatment, there is still a lot of patients that are going to fail this second-line treatment, and there is a lot of room for improvement. So, ECP can be very useful in this setting. So Mohamed already showed you how ECP is working with this leukapheresis, the exposure to the UV light, and the reinfusion of the apoptotic mononuclear cells that have been treated, and with this T-cell apoptosis that have some immunomodulatory effect. And in fact, there is multiple mechanisms of action of ECP that have been reported with some direct effect. It will deplete the alloreactive donor T cells that are responsible for the graft-versus-host disease. It deplete also the pro-inflammatory myeloid cells. It can also induce Tregs, and there is also some indirect effect with the apoptotic cell that will release some anti-inflammatory factors. There is also an uptake of the apoptotic cells that affect the secretion of the cytokine, and the apoptotic cells that can also increase the number of tolerogenic dendritic cells that will decrease graft-versus-host disease. So all this immunomodulatory effect, and the not really immunosuppressive effect, and this explain why this is a safe treatment with low side effect, and in particular a low incidence of infectious complications. So how we can use it? First, in the first-line treatments, and we have this study that were published by Madame Jacassia in Blood Advances in 2019. It was a prospective randomized study of ECP as first-line treatment for moderate to severe chronic graft-versus-host disease. So they received either standard of care treatment, so it was steroids, 1 milligram per kilo, or standard of care treatment plus ECP. We have 31 patients in one group, 29 in the other groups. And they evaluate the response at 12 weeks and also at week 28. And they were also able to assess the quality of life in the patients. So here is the flow chart of the study. So 60 patients were randomized, and some of them have to discontinue, but they were analyzed into the intent to treat. Here are the patient characteristics. I just want to highlight that around half of the patients in both groups have severe chronic graft-versus-host disease, and for half of the patients it was some moderate chronic graft-versus-host disease. Half of the patients have some skin involvement. Some of them have also some liver, GI involvement, or other involvement, mainly into the ECP groups. Regarding the type of chronic graft-versus-host disease, it was some de novo chronic graft-versus-host disease for half of the patients in both groups, and it was some progressive or quiescent chronic graft-versus-host disease for the remaining patients. So here are the response rates. So it was the response rate at week 28. And as you can see here, the week 28 overall response rate was higher into the ECP groups, being 74% against 61% into the standard of care groups. If we look more in details according to the kind and the severity of chronic graft-versus-host disease, the result was particularly impressive into the patients that have some moderate chronic graft-versus-host disease, with an overall response rate in the ECP group of 75%, again 50% into the standard of care groups, while in patients with severe chronic graft-versus-host disease, we don't have differences between the standard of care and the ECP groups, with a response rate around 70% in both groups. What is very interesting is when we look at the quality of life, and this is the answer to one of the questions raised in the poll by Mohammed earlier, and I don't know if you are familiar with this kind of presentation, but it shows you all the aspects of the quality of life that are taken into account, the energy, the emotional, the pain, the physical functioning, the mental health. And in purple, this is the quality of life in patients that receive ECP, and you see that this is better compared to patients that receive standard of care only. So this highlights that even if the use of ECP doesn't translate into a higher response rate, in particular in patients with severe chronic graft-versus-host disease, it allows to improve the patient's quality of life, and this must be one of the goals we want to achieve when we treat our patients, to improve the clinical symptoms, but also to improve the whole well-being of our patients. Next, we'll move to the steroid-resistant chronic graft-versus-host disease and see how we can implement the ECP in this setting. We have first the study that were published by Marie-Florence. It was more than 10 years ago in Blood, but this was a well-conducted randomized study with patients that have steroid-dependent or steroid-resistant chronic graft-versus-host disease, and they were randomized between ECP plus conventional therapy or conventional therapy alone. So at that time, we don't have ruxolitinib, we don't have ibrutinib, so it was mainly steroids combined with calcineurin inhibitors and mycophenolate mofetil. They performed the ECP 3 times per week for the first week, and after it was twice weekly for up to 12 weeks. And they assessed the response rate at week 12 and week 24. So here are the response. So this is the response, so the TSS, this is the total skin score. So they assess the response of the skin. They focus on the skin for this slide. And as you can see here, while there was no improvement with the ECP compared to the control arm in the skin score, it was not statistically significant. But when we look into the reductions of steroids, we find a significant improvement in patients that receive ECP compared to patients that did not receive ECP. In fact, when we assess the cumulative incidence of complete or partial response, it was significantly higher into the ECP groups compared to the non-ECP groups. We then look more in details into the response at week 12 in the ECP arm compared to the patients that were not in the ECP arm. So here, this is at week 12 in the ECP arm. Here, this is at week 24 in the ECP arm. And here, this is week 12 in patients that did not receive ECP. And as you can see here, we have a significant improvement in the oral mucosa, in the eyes, for the joint, it was at week 24, and in the GI tract, and this is another answer to the poll raised in the first slide by Mohammed. We see some improvement in the oral mucosa, the eyes, the joint, and the GI. So it seems to be effective, combined to a calcium inhibitor, mycophenolate mofetil, but what about ruxolitinib? Because now in most centers, the standard second-line treatment for chronic graft-versus-host disease, this is ruxolitinib. So can we combine ECP with ruxolitinib? And we have the single-center retrospective study from Professor Zeiser groups that was published in BMT a few years ago, where they treated 23 patients with a median age of 49 years. It was some highly pre-treated patient because it was not only second line, because the patient has a number of previous chronic graft-versus-host disease treatment of 3 on up to 4 previous line of treatments. It was only some moderate or severe chronic graft-versus-host disease on some very, so as you can see here, some very severe patients. There was, for most patients, several organs that were involved, mainly the skin and liver, the GI, but also eyes, lung, and only one patient have involvement of the musculoskeletal levels. So they receive ruxolitinib twice daily, 5 to 10 milligrams twice a day. So this is the dose we regularly use in patients with chronic graft-versus-host disease, and they perform 2 ECP on consecutive days every 2 to 4 weeks. So it was not weekly, it was every 2 to 4 weeks, but 2 ECP each week patients were treated. Here are the response rate. So this is the response rate after at least 1 week of combined treatment. As you can see here, we have 65% of patients that achieve a partial response and 9% that achieve a complete response, only 26% of non-responding patients. If we look for the different organs, we see some very impressive response rate in the GI and the skin in particular, and some less response rate for the liver, the eyes, and the lung, but we know that in chronic graft-versus-host disease, this is very often the organ where this is more difficult to achieve some good response rates. And here, this is the median time to achieve the response, and it was less than 6 and 5 weeks, so it was pretty quick to achieve a good response in the responding patients. When we move to the adverse event, we have only 26% of the patients that have CMV reactivations, and also 26% of the patients that have cytopenia before ruxolitinib, that on 35% of the patients develop severe cytopenia. This is what is expected, and maybe less than what is expected in patients treated with ruxolitinib in this setting, and no patients relapse. At the end, the 24 months, so this is a long, very long assessment, overall survival was 75%. This is some very good result in this very severe, high-risk chronic graft-versus-host disease, and here is an example of one patient with a very good improvement of the skin involvement, and ECP plus ruxolitinib seems to be a promising strategy to enhance or to improve the response rate of the ruxolitinib alone. So to conclude, chronic graft-versus-host disease has experienced important improvement over the last years with a lot of new drugs approved, but we still need some improvement. For the first-line treatment, we need to have some more effective treatment than steroids alone, and we need also to use less steroids. Maybe we can add ECP in this setting. We have some good response rate, and it seems to improve the quality of life of the patients. Despite this new effective second-line treatment, there is still a significant number of patients that fail this second-line treatment, and we need also to improve the second-line treatment, and ECP is an option in those patients, either alone or combined with ruxolitinib.